Welcome to The Explainer. Today, we're diving deep into a really tough spot in psychiatry, getting the diagnosis of bipolar disorder right. And for you, as residents, getting this down, it's absolutely fundamental to your practice. So let's just start with this question because it really sets the stage for everything we're about to cover. 5 to 8 years. I mean, think about that. That's not just some statistic, that's years of a person's life, filled with suffering, often with treatments that aren't just ineffective, but can actually make things worse. Our goal today is to really dig into why this happens and figure out how we can start to shrink that gap. And here's a number that just, wow, 69%. According to the National Depressive and Manic Depressive Association, that's how many people with bipolar disorder get the wrong diagnosis at first. That's more than 2 out of every 3 patients. And you can see how that one initial mistake can kick off that years-long delay we just talked about. All right, so here's our game plan. We'll kick things off with a diagnostic challenge itself. Then we'll get into defining the episodes, look at the illness over the long haul, navigate those tricky differential diagnoses, and wrap up with what's at stake. The clinical outcomes. Let's jump in. Okay, section 1, the diagnostic challenge. Let's really get to the heart of the problem here and understand why this diagnosis is just so tricky to pin down. So why is this so tough? Well, it's kind of a perfect storm. For starters, most patients don't walk in during a manic episode. They come to us when they're depressed. So right off the bat, they look like they have major depression. Then you have the fact that many patients have zero insight into their hypomania. They might not even see it as a problem. Heck, they might see those periods as times when they were super productive or on top of their game. This all leads to some pretty wild stats. We're talking an average of 3.5 wrong diagnoses before getting to the right one. And in primary care, the misdiagnosis rate can be as high as a staggering 78%. All right, let's move on to our next section, defining the episodes. Think of these as the fundamental building blocks of a bipolar diagnosis. Getting a handle on mania, hypomania, and depression is absolutely key. Okay, let's start with a full-blown manic episode. The magic number for duration here is at least 1 week. And you need 2 core things: an abnormal mood, either elevated or super irritable, and a major increase in energy or activity. As you can see, the DSM and ICD are pretty much on the same page here. You need those extra symptoms like grandiosity, pressured speech, the whole shebang. But here's the absolute kicker. It has to cause serious problems in their life, marked functional impairment, or land them in the hospital. If you have just one of these episodes, ever, that's the foundation for a bipolar I diagnosis, period. Now, let's talk about hypomania. The symptoms, pretty much the same as mania. The difference is all about intensity and duration. It's shorter. We're looking for at least 4 days in a row. And this is the critical part. It does not cause that same level of severe impairment. It doesn't require hospitalization, and there are absolutely no psychotic features. It's a definite, noticeable change in functioning that other people can see for sure, but because it's not as destructive, it's so often missed. And this right here is the key to diagnosing bipolar II. And then we have the depressive episode. Take a look. 2 weeks, 5 or more symptoms, gotta have either depressed mood or that loss of interest or pleasure. Sound familiar? It should, because these criteria are exactly the same as for unipolar major depressive disorder. This is the ultimate chameleon in psychiatry, and it's the root cause of so much diagnostic confusion. The person sitting in front of you, they look, for all the world, just like any other patient with depression. So that leads us right into our next section on the longitudinal course. And this is so important, because you can't diagnose bipolar disorder with a snapshot. You just can't. You need to see the whole movie. We have to zoom out from the single episode and look at how this illness plays out over a person's entire life. You know, it's amazing. Over 100 years ago, Emil Kraepelin, one of the fathers of modern psychiatry, he nailed it. He saw that depression is the real heavyweight in this illness. He observed that patients spend way more time depressed than manic, and that this only becomes more true as they get older. And guess what? A century of research has proven him absolutely right.
And here's the hard data to back that up. This is from a huge 20-year follow-up study. Look at bipolar I. Patients spent nearly half their time with symptoms. But look at the split. Over 30% of the weeks in their life were spent in depression versus less than 10% in mania or hypomania. That's a 3-to-1 ratio. For every week they spend up, they spend 3 weeks down. That's what they live with.
Okay, now look at bipolar II. If you thought the last slide was striking, this is just staggering. They spend more than half their lives symptomatic, but the time in depression versus hypomania, it's a ratio of 37-to-1. 37 times more weeks spent depressed than hypomanic. So if anyone ever tells you that bipolar II is bipolar light or not as serious, you can show them this. The burden of depression is just absolutely immense.
And it's not just about mood episodes. Comorbidity is the rule, not the exception. Just look at this. Almost half of all people with bipolar disorder also have an anxiety disorder. We're talking panic disorder in nearly 1 in 5, plus a ton of GAD and social phobia. It's so important to remember these aren't just footnotes in the chart. They're core parts of the illness that make everything more complicated and make outcomes worse.
And the course of the illness isn't always slow and steady either. For a really big chunk of patients, it's incredibly unstable. That's where rapid cycling comes in. That's when someone has 4 or more mood episodes in a single year. And this isn't some rare thing. It can affect up to 43% of patients at some point. And when you see it, you know you're dealing with a much tougher clinical picture and a poorer prognosis. Okay, section 4. This is where the rubber really meets the road in your day-to-day work. Navigating the differential diagnoses. This is the clinical detective work, telling bipolar disorder apart from all the things that look like it. It's an absolutely critical skill. So your patient is sitting in front of you, depressed. You have to be a detective. You're hunting for clues that point towards bipolarity. Did the illness start early, before age 25? Are the symptoms atypical, like they're sleeping way too much or eating everything in sight instead of the other way around? Does it have an abrupt, out-of-the-blue onset? But maybe the biggest red flag of all is the presence of mixed features. If they're depressed but also telling you their thoughts are racing or they feel agitated and can't sit still, your bipolar alarm bells should be ringing.
The classic dilemma, bipolar versus borderline personality disorder. This is a tough one for sure. Both have mood instability and impulsivity, right? But the key is the pattern. In bipolar, the mood shifts are episodes. They're sustained for days, weeks, or even months, and they can often feel like they come out of nowhere. In BPD, the shifts are way faster. We're talking hours, and they're almost always tied to something happening with another person, an interpersonal trigger. Same with impulsivity. In bipolar, it's episodic. It gets worse during mania. In BPD, it's a chronic, day-in, day-out way of coping.
Okay, let's quickly touch on 2 other big mimics, schizophrenia and ADHD. When you're thinking about schizophrenia, it really comes down to timing. In bipolar disorder, any psychosis almost always happens during a full-blown mood episode. And crucially, between episodes, the person's functioning often returns to a much higher baseline. Now with ADHD, again, it's all about the timeline. The distractibility, the hyperactivity in bipolar disorder, it's episodic. It comes and goes with the mood states. With ADHD, that's a lifelong, persistent pattern that's there from childhood, even when their mood is perfectly stable. And look, before you even think about stamping a primary psychiatric diagnosis on the chart, you have to remember your first job. Be a good doctor. That means you absolutely have to rule out secondary causes. A thorough medical and physical, a deep dive into every single medication they're on, especially things like steroids or even antidepressants, and a careful substance use history. These are totally non-negotiable. And if you see something weird, like a 60-year-old having their first ever manic episode, you better be thinking about getting a brain scan. And the list of things that can mimic mania is long. This is just a sample, but look at the common culprits. On the medication side, you've got your steroids, your L-DOPA, even antidepressants, which we prescribe all the time. On the substance side, cocaine and amphetamines are the classic examples. And then there's a whole host of medical conditions. You've got to keep things like thyroid disease, MS, brain tumors, and yeah, even recent stuff like COVID-19 on your radar at all times.
All right, our final section, the stakes. Let's bring this all home and talk about why getting this right is so critical. This isn't just an academic exercise. For our patients, the stakes could not possibly be higher. Getting an early, accurate diagnosis isn't just a clinical goal, it's a moral imperative.
Let's talk about just being able to live your life. 40 to 60%. That's the unemployment rate for people with bipolar disorder. Just let that sink in. That number represents a devastating blow to someone's ability to hold a job, to be financially independent, to build a career. It hits a core part of who they are. And then there's this, the ultimate stake. 15 to 20%. That's the estimated percentage of people with bipolar disorder who die by suicide. That is a mortality rate up to 20 times higher than the general population. Let's be very clear. This is one of the deadliest illnesses we treat in all of psychiatry.
So that brings us back to the question we started with. And I want to leave you with this, to take back with you to the wards, to your clinic. Knowing everything we've just talked about, the burden, the mimics, the stakes, how can we, in our own day-to-day practice, help close that 5 to 8 year gap? What's the one thing you can do differently for the next patient who walks through your door to make sure they don't get lost in the system? Thanks for joining me for The Explainer.